to item number 23, which I believe is a overview from Health and Human Services Behavioral Health Division. Marilyn Mann, HHS Director, will be, along with her team, giving a presentation on the Behavioral Health Division.
Good morning, Marilyn Mann, Health and Human Services, and I have some of our key behavioral health team leaders who are going to be providing the majority of this workshop with you. Anna Scott, you know, is our Assistant Director. Kimball Pierce, our Deputy Director. Christina Pope is our Clinical Administrator. And Katie Grisham is our Addictions Program Supervisor. So we're excited to come before you today and provide you a little bit more detail on our Behavioral Health Division. We were here a few weeks ago about the broad brush overview of Health and Human Services. We wanted to delve a little bit more on some key initiatives and successes and things that we're doing in our Behavioral Health Division. We are mindful of your time and the time of the public, so we'll try not to get too much in the weeds and keep. But you know us program people, we like. I know. Christina would be more than happy to do that. So with that, I'm going to turn this over to our behavioral health team. Anna and I are going to be standing by because we'll be here to help clarify anything from that larger picture scheme. So.
Hello, I'm Kimball, and I'm the Deputy Director as of last January 2022. And so and this is Christina, as you heard, Katie. And so the first slide is our mission statement. And it has been a great pleasure for me to get feedback from all of our staff on how to develop this mission statement, which is to honor and respect each client's lived experience and to offer services that are client-centered and culturally relevant. Do you guys have any other things to say about that? We'll just move on. You guys can see the work chart here, and there's a few empty spots, which we're hoping to fill soon. But with the few people we have been able to do an enormous amount of work. And I am genuinely appreciative of the hard work that everybody does. The programs and services are divided between our community mental health plan. We have a Medi-Cal managed care plan for specialty mental health services. That's outpatient services. We provide mental health services for adults and children with serious mental illness. And if you want a more in-depth definition of that, we can invite the person in who had the read in his hand. I'm sure he'd be glad to share with you about that. We provide outreach, assessment, and integrated services to adults with severe mental illness and co-occurring diagnoses, including medication, psychotherapy, and outpatient rehabilitation, groups, case management, and residential treatment. We are, by contract, required to provide 24/7 access to crisis services, which means that people can call 24 hours a day, 7 days a week, and have somebody to talk to and to be referred for services. Or if they're in crisis, then we go to the next level, which is to get them to the hospital as soon as possible. I'm the LPS conservator for Inyo County. So for people who are unable to live independently, we also serve people who are gravely disabled and need a higher level of care. We have Progress House, which is a residential facility that provides a home-like setting for individuals 18 to 58 with mental health conditions that require 24-hour care and support. So we're looking to expand the Progress House so that we can accommodate more people. We feel like since the pandemic, it had been underutilized. And so we're really looking to provide more crisis stabilization and long-term care for people in Inyo County.
Can I interrupt?
Yeah.
So Progress House expanding, you can expand.
Well,
You have plans to?
meaning the scope of service.
Okay, gotcha. Yeah.
We're looking to kind of build out what we do a little bit there, like maybe have a nurse there 1 day a week, 1 full day a week, to
Okay.
just see patients who come in for medication management,
Okay.
and to just be another presence at the Progress House. Hoping to hire people so that we can more residential caregivers, so that we can increase our census and let people know that we're available to provide long-term care. We want to be what we were supposed to be a few years ago. Marilyn was saying, that since the pandemic, things kind of need to be shored up and pulled back together so that we're providing that kind of services for community members who need 24-hour care.
So with that, just trying to get clear. So with that, so for instance, if there's an acute issue, maybe it goes to the hospital, but there's no medical issue, so they're released, and then there's no ability for conservatorship or transport, would that mean that Progress House could fill that role?
Yeah, I think that what I'm feeling kind of time pressured. I'd love to go into this more.
Oh, sorry.
No,
Let's
that's
get to you.
okay. And if you guys want to jump in.
We're allowed to like.
We can-
Blow up your.
We can do that. Don't let that.
Keep it here all week, that's right.
What we were kind of thinking about is, doing more respite care and having more providers, more accessibility to our psychiatrists, why people are there, and therapeutic oversight. So having more and more services be there to help the staff that are there, because it's quite a job being a caregiver.
Yeah,
They've been short staffed for quite a while.
yeah, exactly.
So does that mean that there's a higher level of care or a higher level of need that take care of that progress?
We have a huge need in this county for people to, who have mental illness and who are not able to live independently, to have a place to be and to have 24-hour care and medication management and therapeutic services. And so what we really want to do is what Jennifer was saying. Can I call you Jennifer?
You can call me anything you like. That's fine. It's all good.
But what we want to do is provide comprehensive care for people who are unable to live independently. And as you said, if someone goes to the hospital and they have been through the 5150 process, and maybe they're determined to have a grave disability, then we want to be able to take care of them to the degree that we can. We can't handle certain, individuals who have complex medical problems, but we can certainly contribute and build that capacity so that maybe people can live independently if they stay compliant with a treatment plan and they're stabilized on medication. And the hope is that Progress House can rebuild capacity.
Yeah, well, thank you for that. I know that's got to be a task, and wishing you all success.
I would like Christina to talk about the wellness centers.
Can I get one more little follow-up on that? So you said that the census, you're trying to up the census. Has the census been
It's been
low?
low, yes.
Okay,
And primarily that there's a lot of different factors that play into that. But, some of it is that we're seeing escalations in the severity of mental illness. We're seeing fewer resources to stabilize people. So we don't have the ability to stabilize people because we're in a psychiatric facility. There aren't any nearby, as you well know.
Yeah,
So since the pandemic, and we've seen escalations in mental illness and substance use that complicates things quite a bit. So the ability to care for people who are psychotic, unless we can get them stabilized, we don't have the capacity to take care of them.
right.
So that's one theory.
And I know that, if you can find a bed for someone, outside of the area, that it's not ideal to ship someone back.
No,
So
I mean-
where we can take care of our own people here.
yes, that is my dream.
Yeah, yeah.
To be able to, say we have the capacity to care for our people here. And we have the psychiatric care available, we have behavioral health nursing available, we have clinical staff, we have case management. We just really need to build back capacity in terms of staffing.
Yeah.
Because we are 24/7, and it's probably, as you well know, it's really hard to staff a facility 24 hours a day, 7 days a week.
Yeah.
And, but I feel really hopeful that we can do that.
Yeah, at some point I looked at a conversation about innovative ideas of ways that rural isolated areas are.
Oh, you'll never shut me up. It's, it's really, really, important in a rural county like this, especially when people are so spread out
Yeah.
and people are so isolated. We have some challenges here in terms of transportation. And it's really, in my view, never ideal to ship a person out of county because they're on a 5150 hold to a psychiatric hospital, only to be released,
Right.
just, a day or so later,
Then what? Yeah.
having not,
Yeah.
maybe even been more traumatized by this.
Right.
So,
That's really encouraging, and I wish you well. Your dream may have come true.
we have a lot of great ideas.
Yeah.
And we want to train people in the community to be the helpers, which we will get to.
When we were working with the Vision 21, which is a VA-centered behavioral health, mental health program, they were referring to us that which I didn't even believe, but that the not digital, online telehealth, psychiatric, was actually very effective, like 80–90%. And I thought, really? But is that something that you can utilize?
We do,
You do?
yes.
Yeah, I figured you would. But
So what we're doing now, we have a great team of an emergency room. So because of AB 2275, which says, we have to provide a certification hearing for people within 7 days after the raise of 5150. So the idea that we would get, we can contract with someone to provide the certification, we can telehealth. We can do the psychiatric evaluation via telehealth. So that is going to be a step toward caring for people and, seeing if we can then transition them to the progress house so that they can be in place and so that we can use the natural supports to build that capacity.
very interesting. Thank you. It's really encouraging. So I will not track you anymore.
And I love the questions and just I would love Christina to talk about the wellness.
Yes. So our wellness centers, we have one motion, Bishop and Lone Pine, and they're staffed with case managers. We have a few full-time and part-time case managers, and it's become quite lively in the past few months where people seem to be coming out of the woodwork, mostly because of the weather, but also since COVID. That's been was very difficult for our wellness center. They were the staff members that were really out in the community during COVID, doing a lot of things, finding people, helping them get what they need. So now they have a nice warm place to come and have coffee, and there's many groups that are going on there right now. It was a soup group, but now we call it the lunch bunch, where we're learning healthy cooking, lifestyle choices, also a recovery group going on there. And Lone Pine, we're wanting to really kind of beef up the Lone Pine Wellness Center a little bit more, and so people can do their laundry. It's a place where people come in and could do laundry, get groceries, get some support, get on social services, get access and support. A lot of times they're there to get emotional support and get a sense of community. So everyone's been a bit isolated, and including our unhoused population. So having a place for people to come together and build community and connections, that's one of the main functions there, I think. Anything more?
You're on.
You're up.
So under behavioral health, there's a group of programming often called SUD, substance use disorder programming. Often what we provide is directly related to court order services. So things like drug court, DUI programs, Prop 36, things like that. We're also in the jails providing services like assessments and group counseling. And we've recently been building an intensive outpatient program. So there's a bigger menu of options for people who walk in or have outpatient needs, including individual counseling, group counseling, and looking to facilitate some family counseling as well. We are in the schools with prevention and doing we have a lot of like ideas percolating right now for how to do more educating and more destigmatization in the community. We've been involved in some awareness events as well. We also treat a specialty population called perinatal. So women who are suffering from substance use disorder, who are either pregnant or 6 months postpartum. We have services specifically for them as well. And yeah, we're thinking about how to really develop more adolescent specific programming. That's kind of our next goal, because we have a lot of youth in the community and a high need for not only group counseling related to probation and things like that, but also education and even family dynamics. So yeah, that's a little bit about what we're doing.
I got a question.
Yes.
So I think, so you have two, so you've got
Mhm.
two full-time addiction counselors.
Yes.
And three.
Three part-time, yep, and a new specialist.
Okay.
Mhm.
And one of the things that I've always been impressed about going to drug court graduations is how people are graduating, the people that they think the most are off other people.
Yeah,
And, so you basically live experience.
Exactly.
Effect.
absolutely.
Just a question of like, are the thoughts on how to utilize those folks, like maybe we can pay those people and like do some force expansion.
Yes. Yes.
Because it's all the services you're doing great, but if we could get to the non-justice involved people
Yes,
before they become justice.
Absolutely.
That would be a good thing.
yeah, absolutely. I haven't thought a lot about, like necessarily paying specifically people, but one of the things that's really, really important for essentially like recidivism and relapse prevention is having alumni services and a beefy alumni program. And so that's one of the things that we've been talking quite a bit about because of what you're talking about, that sense of community that you see at the drug court graduations, because it's the clients that are really showing up and supporting each other. And they like to take that recovery and wellness back into their community. And so the point of that, I guess, would be not only to have a space for them to still be together, but also to bring that into the community. The other thing is a couple of our recent success stories are seeking employment in the Inyo County system. So they are actually directly giving back to their own community or seeking to do that, which is really, really awesome. Yeah, we definitely support that.
Can I just say too, as a promo, there's drug court tomorrow, right?
There is drug court tomorrow and there's a graduation.
Graduation.
So if any of you
Yeah.
guys want to see the magic that happens as a result of someone's working really hard for over a year
Yeah.
and wanting internally to change something about their lives, I would highly recommend showing up to court tomorrow. It is awesome.
I'll be there.
Yeah. Oh, really? Oh,
I was there last one.
it's
It was
awesome.
Amazing. Yeah.
that gives you chills.
I just wanted to add, your board did approve a parent partner for our first program, which I think is the next in the slides, as well as a peer support specialist. They'll be working out of our wellness center. And that peer support specialist may come with having experience navigating mental health systems or SUD systems or both. And we do have an offer going out either today or tomorrow to someone to fill that peer support specialist. So, and I believe we had an offer go out for the parent partner, just to tag on to your comment. Sweet.
Yeah, I feel like there's a couple of things. I mean, this is just my feeling, but I feel like there's more general interest in sobriety and
Yeah.
exploring different kinds of sobriety in the broad area and in the broad community. And then I feel like there's a destigmatization addiction
Yeah.
from a shame moral issue
Absolutely.
and more to a illness
Absolutely.
that is curable and that people can deal with. And so I think both of those things are positive. And so as much as we can help the broader community with whatever desire to get sober.
I agree. And I've seen that as a result of sort of in the last 10 years, probably learning more about trauma and how trauma really can beget more trauma, and also what are some of the consequences. Like, I think over the years with substance use treatment specifically, there's been this pendulum swing between, do we treat them as medical patients? Do we treat them as criminals? And it goes back and forth. And really it's not isolated from all of the other mental illness that we see. And I think part of our mission in the last couple of years to become more trauma informed, we as not just an organization, but also as a community is seeing that. So, and I think it's really cool.
A couple of weeks ago, Nate and I did a community meeting in Charleston. And that area is, I wouldn't say it's exploding, but it is, every time I go there is more things happening in Charleston. We had, I think, around 40 people come to a community meeting in Charleston.
Wow.
All of these programs that are on here are things that I have to say, people in Tacoma, Mississippi, and Charleston, probably need, or at least
Yes.
potentially need. And I guess I'm not asking you to necessarily do something, but I do think that we need to recognize that things may be changing out there. And I mean, we had 5 discussions with those people for about an hour and a half. It could have gone for much longer. And I would just say I get it that we're probably really doing a good job on the north end of the county.
Yeah.
I mean, I can tell. And I just think there could be a challenge at even some basic level in the southeast part.
There are huge challenges, and I'm really glad that you said that. And I agree. I do think we need to do something about it. Just getting down to Lone Pine, we see that we need to do something about it. And so I'm glad that you said that. And it absolutely is a need.
I think we do have a task force, we call it a Charleston View Task Force. And that it might be smart for us to start to include somebody from HHS at the very least in that task force to start thinking about how we're going to address challenges there.
That sounds like
So just to assure you that I'm aware that our communities feel left behind. And we are offering telehealth in remote patient include phone. And even though it isn't the same, but we have to get really creative and how we conduct groups and how we offer psychiatric consults and therapy. So telehealth is what we do. I do support capable saying is what we work that we need to listen. Challenges are and for people other communities that are in the shadow of the Eastern Sierra. So but
Don't take anything I'm saying as criticism. It's really as much warning.
And it's been a long,
Exciting in a certain way.
And it's been a long-standing challenge, and we have at different times had contracts with a couple of different providers out of Pahrump, which has been helpful. Navigating the system and the Medi-Cal reimbursement does not make us always the most attractive contractor. So you know, it ebbs and flows with that. We do use the telehealth, and in fact, the old employment eligibility, the office that gets used over by the library,
Yeah,
that is where we set up telehealth on a fairly routine basis. But this is an ongoing challenge, and one that we're to continue to look at
right.
finding ways to meet.
Well, and more than anything else, I was really surprised at, well, I get calls and people say, oh, things are exploding out here. Well, so I've been out there 2 or 3 times in the last couple of months, and they really are changing. There's just more and more people coming in to that area. So it isn't, not a criticism as much as just a heads up.
Yeah, I wasn't feeling criticized. I was feeling like, wow, that's great. You have so many people.
I've been out there quite a few times in the past few months, and I really feel like creating a peer partner, kind of getting a system there for peer partners, because there's many people there from all walks of life with all licensures and education, and we need to get the community together. So that would be fun. That's the exciting part.
That's neat to do. Yeah, the perspectives you have.
Let's see. Oh, so we're gonna, our next slide, programs and services. Right here, we're highlighting our first team, the Family Intensive Response and Strengthening Team, which just now has come under behavioral health. So we use a wraparound approach. I mean, kind of before we get into just that team, I kind of want to talk about the broader umbrella of our services. We have adult services, as well as our adult team, child and family team, and the first team. And I'm fortunate enough to provide clinical supervision for the clinicians, the case managers. And really, the first team has been implementing wraparound principles of planning. We're using a lot of was a trauma-informed evidence-based practice. But what we get to do clinically now is really slow that down and utilize all of our different systems. So let's see. So with our child and family team, we work directly with a lot of the youth that are coming through the child welfare system, our foster youth, and then we get to touch the resource families as well, and the parents, and kind of we're trying to share some education and way of being. So through the clinical supervision, we do reflective supervision, which is an idea where we're trying to assist people in an understanding and envisioning what's going on in the mind of the other. So it's kind of brings in attachment, neuroscience, and since we've all been through a collective trauma together through COVID, the wraparound team, the first team, has been doing this all along with intensive care coordination, in-home intensive home-based services. So now we're all just kind of infiltrating it, it feels like. So with that, a lot of education and neuroscience, and the reflective model, which is a lot of attachment. I like this because it helps me, reminds me of all those very important things. That's how we're building community with each other. So yeah, I love overseeing the first team, because they really get to bring families together. Cal Ames, which you'll hear about in a moment, is talking about how intensive care coordination is a huge theme. So it's not just one provider. I mean, I'm a psychotherapist at heart, and I love to sit in my dimly lit room with my scarf and my velvet pillow and talking very nicely about things and our attachment issues. But that's not what our community needs as much anymore. We need that. We definitely need that, a warm, safe place. And we need to learn how to be safe with each other, especially coming out of the pandemic. So I think the wraparound model is just, we want to highlight that. And our staff just went to a great training in Monroe County, actually, about that. So, Yeah, and I can talk about that for a while.
Great picture, by the way.
That is Kimball's grandmother. Yeah.
I do have a question about the first. So first, I think it's just fantastic that this program first came out, because I came into this whole thing from foster care side. So like, fixing the family before it gets to the same.
Tending to.
Right. So the question I have is why is the first team under behavioral health, social services and child development?
Okay, sure. Go for it.
So it was originally established under social services. I, in fact, was the first person directly supervising the first team when it was just called Wraparound back in 2011. And we kept it under social services for the longest period of time because the majority of funding at that time and at the initiation came from diverting youth who were either being placed through child welfare or probation from a group home setting or helping people transition home. The numbers have shifted significantly. We don't have the same number of youth going to group homes that we did at the initiation of our first program. And as that shifted, our funding sources needed to change. And so when we established first as a separate from just the social service funding alignment, we brought in Mental Health Services Act funding. We brought in some SUD prevention funding and some First Five funding so that it became broader. We also looked at how do we not only identify and continue to serve those people, those youth and families who are at risk of group home placement or higher level placement, how do we get those younger kids? So we started serving families with youth as well as young children. So we have families who might only have 3, 4, 5-year-olds in their household. As time, move forward, a lot of the services overlapped a lot with our child and family behavioral health team. A lot of what's needed is around that addressing the whole family, not from just the case management, but also the SUD and mental health needs. So we about 2 years ago shifted our team under the supervision of behavioral health, and in order to really allow for more fluidity around treating the behavioral health issues.
Thank you.
I just want to say that I am very, very fortunate to have Christina and Katie running these programs. Excellent leadership and ability to bring people together and to offer groups and services that people really benefit from. So we have the funding streams part here, and I would like to just rush through that because I would really rather talk about other things. So does everybody know what realignment is? Okay, so
We need realignment in 90 seconds.
okay.
No,
It's your vehicle integration tax, it's kind of, one of those things that is a blur. But nonetheless, we do rely on it for things like giving our clients in the jail the services that they need and deserve. It also helps to fund our DDB programs and services. And our Medi-Cal and drug Medi-Cal and Medicare billing are, those are the direct services reimbursement where we actually bill Medi-Cal and we bill Medicare for direct services. And, the way that that's happening now is going to be way different than it used to be. Our drinking driver programs are fee for service. And so people have to pay to take those classes, and sometimes, you know, the costs are not completely offset by the fees. So there are other funding streams that we utilize to make that work out. The mental health block grant is in large part what funds Progress House, and that's probably going to change a little bit in this budget year. Substance abuse block grant is what funds perinatal services and our youth adolescent programming. And it is substance abuse, mental health, the SAMHSA. We are kind of under that umbrella in terms of what drives evidence-based practices and services. But the substance abuse block grant is hugely beneficial to as it reaches youth and adolescent outpatient treatment programming and services for women who are pregnant and who are IV drug users and who need just the kind of wraparound, you know, services that we're talking about with mental health. We need, as Katie said, to involve family and community so that we can, right from the very start, we can assist women in changing the legacy. And Mental Health Services Act is Prop 63, started in 2004. There are basically 4 different, or maybe 5 different arms of Mental Health Services Act, the biggest one being Community Services and Supports, which is where we fund services and programs at the wellness centers, and full services partnerships, which is essentially another kind of a wraparound program for people, where the slogan is whatever it takes. So when, you know, we have families in that program, or an individual will look at, you know, what life domains need a little bolstering. You know, it might be that they need medication. It might mean that they need dental care. It might mean that they want to take some creative classes, or they want to learn yoga, or they want to, you know, increase their overall well-being in some other way. So a full services partnership would be what we would use to build that network around people. The workforce education and training, as we're talking about peer partners and parent partners, and building out our workforce and giving them education that's relevant to our Inyo County particular culture. It might mean a lot of trauma-informed continuing education. It might mean, you know, more cultural awareness in terms of how trauma has affected Indigenous people. Whatever we need to do to help train our staff to better understand these issues that are unique to Inyo County, and also to take care of themselves. So we want to provide continuing education and training, not only so that we can serve others, but so that we can take care of ourselves and keep ourselves healthy. And I know I'm rushing through these things, so if you have any questions, just say, hey, time out. And then we have the capital improvements funding stream is what we would do, for example, we just purchased a new electronic health system called Credible. So everything, of course, went to electronic storage, no more paper files. So we had one called Anasazi for a few years. And then when I came on board, we were in the process of, you know, preparing for Credible, which is the new electronic health record. So that would be an example of money that's used for a capital improvement, or if we wanted to buy a building, like for the wellness center or something, or make improvements on existing buildings that, like the wellness center in Lone Pine. So that's kind of Mental Health Services Act. And then last but not least, private insurance, which we have contracts with Anthem Blue Cross and with Mental Health Network, where we refer people, or, you know, if people don't have any other, if we are primarily Medi-Cal, we serve people who are would typically not be able to access services if not for Medi-Cal or Medicare.
That's a question.
Yes.
So statewide, I guess, there are some counties that are not spending their MHSA funds. And the government has been making kind of a big deal about it. They basically, the homelessness hasn't been solved because counties aren't doing grant, spending all of their services. So are we utilizing our full allocation on that, or do we have, I see Melissa.
Come up with an answer.
So I don't find this slide boring at all. So this is my favorite slide. So for MHSA, when I first came, behavioral health had some back years that we hadn't spent, but we're pretty close to spending what our base allocations are. What's really hard for small counties is you put that towards staff a lot. And if there's one vacancy, that can lead to not spending money. But with Credible and some of the changes we've done with the Lone Pine Center and putting in new flooring and all that stuff, that's adding some of that, using that MHSA for one-time occurrences, which has really helped. So we're working on the 21-22 cost report as we speak. So but last year we used all of our base allocation and a little bit more. So we are getting there and spending, and we don't have that mass pile up like other counties do.
Okay.
Yeah.
Thank you.
Good job. And if you don't have it all used, Katie, you're making me want to do some yoga here. You could lead us. I see your activity. Sorry. No, I'm getting inspired by it. And when Bill said yoga, I thought, let's go.
Yeah, that's right.
She'll take you on a run.
Okay.
Yeah.
It'll only be 100 miles.
Leave me behind in quarter mile.
She's our runner. She won a 100-mile run.
You're kidding.
Yeah.
My gosh. That's like endurance running. That's
Yeah.
amazing.
Thanks.
Wow. Congratulations. Thank you.
I did want to add one caveat to the DDP, the fees. The drinking driving program is intended to be fully self-funded with fees. We have not had an adjustment to our fee structure since 2011. So we have, as a team, been working behind the scenes trying to take the steps that you have to go through to get the state to approve it and then bring it to your board. We anticipate bringing an item to your board within the next month to 2 months at the most, requesting. We're going to need to do some work with county council around adjusting it from an ordinance to a, what's that R word? Resolution. Thank you. You know how your mind just goes blank?
Yes.
Anyways, to a resolution so that we can embed in the resolution language that allows us to increase routinely with the approval of the state. So I just wanted to alert you on that because I know that Danelle is listening to this somewhere with Amy and would want me to correct that this is not intended to be anything but self-sufficient.
Is the drinking and driving program in person?
Yes.
only? And is it offered anywhere?
Yes, you can take, if you want your California driver's license returned to you, you can do that program in any county.
Well, it's not offered in Little Pine.
It's in Lone Pine once a week. Yep.
It is in Little Pine.
Yes,
Okay.
It's held once a week.
it is. Yes.
At the wellness center.
Oh, I didn't know that. Wow. Okay.
Which was funded by the NHS, in part, I should say.
Okay.
I forgot to add that SABG, the Substance Abuse Block Grant, also funds some prevention services. So that's really important, particularly for the schools. So let me see, where are we? Are we at the year in review? Okay. Well, we hired a new deputy director. She here? It was my dream to come here. And I came from Tahoe. And
Yeah.
so this was like a dream come true for me. And it still is. So what our year in review, I kind of added a little poetic language to that. It was really huge to adjust to a new space for everybody, even to come back to the office. And for this crew, they came back to a whole new office. So in addition to coming back in person, it was to a whole new space. And everybody went through the adjustment of learning to work together again in community. And it's, working from home, you get to be in your little bubble, and, it can be pretty nice to do that. And so it's a huge leap to come back to working in community again, particularly with a new person who's in the role of a deputy director. And everybody did their best work in being transparent about the struggle, acknowledging that it was difficult and that we had a lot of challenges in all of those adjustments. And it's not like you have your little office that you go to. We're in a big space with cubicles. And so it was really fun to watch how people decorated their little spaces and how it becomes very personal. And so that was this whole past year has been, okay, how do we do this again together? How do we work together? How do we work as a team? For me, this work I've been doing for 28 years now has never been felt better than when it's with a lot of team members. So for me to work with probation, Katie to work with probation, Katie's, her substance use crew works with probation really closely, works with the court really closely.
I would like to add that moving into the new building has been really cool for connecting with services directly. I mean, we used to have to drive across town to behind Taco Bell to talk to probation, and now we can walk across the hall and they're accessible, and even go upstairs and talk to CPS. So being able to connect clients to services while they're still in the building, instead of letting them leave Grove Street and hope they make it to wherever they're supposed to be going, has been actually really cool.
And don't get run over.
Yeah, it's something.
Yeah.
I think there's a little challenge to that too, as well, because a lot of people are very intimidated to go into the building because all the services that maybe they were once in contact with, like if they're just coming for therapy, they're having to navigate through.
Yeah, essentially.
A little bit. So
Yeah.
Yeah, a little bit of both.
Absolutely.
It's a different environment now.
Sure.
Yeah.
It is a really interesting dynamic, because what we're trying to teach people is we're all in this together. If you're involved with CPS and you're involved with probation and you're involved with the substance use program, it's all okay, because everyone wants the same thing. Everyone wants the same thing. We want you to walk out of these programs feeling strengthened, and that you have identified what those strengths are and you've been able to build on them. And so that's a really, really good point, being together in the same space. One of the missions that I had was to see if we could reduce the anxiety around on-call, having our clinical staff be on call 24/7. It's really hard to be raising a family and working as a therapist or a substance use counselor or a case manager and not feel like you can rest at night so that you have what you need for the next day. So what I would like to do is see how well we can reduce the enormity of what has been crisis in the past, how you define it, to, well, maybe this isn't something that requires this, we've got to get you to the CSU or to the psychiatric hospital. Maybe we can stabilize you right here. And maybe we can utilize some natural supports to kind of reduce or change your definition of what crisis is. And so that's better utilization management, to see if we can calm things down right here. with Marilyn and Anna's support, we're able to pilot a program where we have a 24/7 triage service, so that it's sort of like a 988 system, where there's a person to talk to de-escalate in the middle of the night, so that we have that resource for people. We're seeing how it works. I think personally, I would rather have that be in the community here, because people know the resources and people generally know one another. So a lot of clients are known to us. And so if someone calls and there's some random person they never talked to, they might not be as open as if they called the 24/7 line and were able to connect with someone who knew who they were. Maybe that's true, maybe not. But the goal is to reduce the stress on clinical staff. We're experiencing in the state of California a huge shortage in behavioral health staff. So my response to that is we need to train people in the community to be the helpers, provide crisis intervention training to community members, and so that we can use our clinical staff just for the really, really dire emergencies. Did you guys want to say anything about that? Okay.
Can I jump on that?
Sure.
Because there was a couple of the points that I was going to ask questions about, and it's a long topic that we'll touch on
Yes.
side, but I was wondering how 988 implementation was integrating your work.
Well, I just spoke to someone from Optum San Diego last week, and 988 is being rolled out. And I think that there's a lot of conversation in California now about, regional call centers, who should be fielding those calls. Because what we need are, people who answer those calls to be really familiar with the resources in that community. So right now, the closest one to us is in Los Angeles, the regional call center. But in conversations with Christy, who is with Optum San Diego, she said, they're staffing it so that the goal is to make sure that if we have a group of counties, that person who answers the phone is familiar with all the resources in each county. So so far, it's working. But I don't know if we have any measurables as far as how effective it is compared with having a service like we have right now, who's answering for 4 different small counties. But the people who are fielding the 988 calls are trained in crisis intervention, and they have a lot of experience in de-escalation and suicide prevention, how to have those conversations and how to immediately respond if someone isn't able to keep themselves safe. So
for those who don't know, 988 is the suicide hotline.
Yeah.
It's nationwide. Call.
Yeah. And I mean, what we want to do is, habituate people to calling that number, not just when there's an emergency, like someone is feeling like they want to kill themselves, but someone who is in emotional distress and wants someone to talk to, who really has the skills and ability to meet them where they are and de-escalate them.
So if I understand, oh, sorry.
Yeah, just finishing up on this topic. So going beyond that, there's a lot of discussion about crisis response and having alternatives to law enforcement response in areas where with mental health or substance abuse issue that, perhaps be more effectively handled. I know that it's a huge challenge in rural, lightly populated area, but I've seen some presentations by Whitebird up in Oregon, who has some models that are doing stuff. I know the state of California is looking at how can they expand that. So do you have any, and we don't even need to talk about that now, that's a long discussion, but it's something I'm quite interested to see if we could be on the cutting edge of how to pull that off.
Well, we were going to talk about the CCNU. I think when we talked about that,
I do think we have it later in the slides, but this is a good introduction to that. So what we refer to in California is the crisis care mobile units, and that is really kind of the same idea that you're talking about, Supervisor Griffiths, where there's some behavioral health intervention, hopefully early before there's a full-on crisis, but trying to find that that balance to getting in with someone, getting access to someone to de-escalate before it becomes a law enforcement issue, or an issue that's going to impact our emergency room. So we have just gone through about a 5-month planning process. We've just submitted our planning, our plan, and are waiting to hear about additional implementation funding. So we do have about $300,000 to get started. That's not enough, really. Many other counties that were a little bit further ahead were finding that it was costing them upwards of $1 million to get a full unit going. We don't anticipate that's going to be the amount for us to really get something up and going, but you know, we really need to focus on sustainability. There is some Medi-Cal reimbursement as long as we can meet the requirements, some of which are a little ridiculous for small counties. For example, a 2-hour response time. We know that we can't physically respond within 2 hours to every single crisis, just given our geography. So we're working towards advocacy for additional implementation funding. Bottom line is that this is going to be a requirement regardless to have in place by December 2023. So we are moving in that direction, and really we're really behind the intent of the unit. It's just a matter of getting the right balance of and being able to hire the staff to get it up and going in a way that works, so that we're not only not needing $1 million a year to keep it going, but in a way that really works for our community. So more on that as we move through the rest of the calendar year.
It should have been patient.
Yeah, I think that what I keep coming back to is caring for people in the community and having the capacity to do that. And you know, what that's going to take is everybody participating, volunteers, paid staff, people who have been through it and who can relate to people who are in crisis. So thank you for asking those questions. So next one is reducing stigma, I think. And so we're going to this is a great segue, because training community members and case management staff is an excellent way to build capacity. And it doesn't cost that much compared to repeated hospital stays. It is a great investment. It is a great way of empowering people and telling people, you know, because you have struggled with depression, or because you have struggled with post-traumatic stress disorder and all of its friends, anxiety, and you know, other substance use problems, this is why you're valuable. And so, you know, having been through these things myself, I feel like my experience with that helps me to be with people in a way that is more human and more connected. I'm not afraid to talk about it. And I think more people who are in the public eye, or who are, you know, are well known in the communities, need to come out and say, I've had that experience. I get it. And I want to be trained well enough so that I can compartmentalize my own experience, so that I'm not, you know, fusing with you, but I'm relating to you, and I'm empathizing, and I'm able to connect in a way that maybe, like in AA, there's nobody that can talk to an alcoholic like another alcoholic, right? So, so public awareness means that we talk about it, and that, you know, we're doing as much as we can to get it out in the media, to have these public conversations, to have the people showing up at town hall meetings and community centers, and that we are inviting everybody to the table. So when I have meetings and I get to invite Northern Inyo Hospital's emergency room staff, or, you know, we invite probation to meetings, or we're coordinating amongst all the different divisions within the Health and Human Services Department. It has to happen in that kind of multidisciplinary way. And I'm really pleased that we do that here. And so looking forward to 2023 and beyond, we talked a little bit about the CCMU already, but CalAIM, which is the acronym, the acronym is California Advancing and Innovating Medi-Cal, means that it's no longer going to be this teeny tiny little lens of, well, you're going to meet this list of diagnostic criteria and we're going to diagnose you with this, and then we get to be reimbursed, you know, because we're coding it a certain way. What CalAIM is intending to do is, again, to coordinate care based upon life domains and how well you're functioning in those life domains. Jump in anytime if I miss something. But how are you doing at work? How are you doing with your physical health? You know, do you need dental care? Do you need help with housing? Do you need help with getting your needs for food met? What about your spiritual needs? What about, so really looking at the comprehensive whole person. And so that's what Medi-Cal is striving to do right now with CalAIM. And so the research has shown that when you include family as a person defines family, or your support system, and when you ask people, what do you want? Where do you feel like you want to increase your resilience or your strength? And we don't pathologize daily life. We don't pathologize, you know, if you're a person who hasn't been able to find a home, we're not saying, well, something is wrong with you. We're using the trauma-informed approach, which is what happened to you? What happened to you? You know, how did you get to be where you are? And where do you want to go from here? And you get to define what the plan is and how we get to serve you in making that plan happen. It also involves interoperability of health systems so that our mental health system is talking to the physical health system. And, you know, we're able to do that data exchange seamlessly and smoothly so that we're not sending people out the door saying, well, here's a release of information that you get to take over here. And then it gets dropped and, you know, you never get to have your mammogram because they never got that before. So, you know. The big deal is, you know, the change in how we're going to be billing for services with Medi-Cal. It used to be cost per unit. And it to me is like the dumbest thing ever. And so now it's changing to fee for service, which means that we bill, you know, in the same way that I used to bill through a regular insurance company, which is using the CPT codes for behavioral health and billing for time increments, rather than Medi-Cal giving us money and then we bill against that through the year, and then it has to all be reconciled and they're 5 years behind. And, you know, instead, this seems to me to make more sense. It's more immediate. We're probably going to be able to track how well the services are working better. And so all of that is improving healthcare access. The bottom one is for people who are transitioning from incarceration to the community. And so in my view, people who have been in jail for a while and who are coming out need immediate access to mental health services. They don't need to be put through a bunch of hoops in order to get the help they need. So All of these are part of what California's Medi-Cal system is transitioning into.
Yeah, and if I could just add, your board has already supported our efforts in CalAIM with the integrated caseworker who will be doing that eligibility for Medi-Cal 90 days prior to release. The question is, we don't always know when the release date is. So there are some challenges for that, but this will also allow us for certain services such as medication-assisted treatment and initiation or certain types of services pre-release, be able to provide those and bill Medi-Cal, which we've not been able to do before. I want to be mindful of the time and ask you to go to the next one. Unless you guys have any questions on CalAIM.
No, that was good.
I'll ask you later.
We can do a one-on-one tutorial.
If there are more questions on CCMU, maybe that would be.
Yeah, I do want to, on the CCMU, I do think Anna sort of talked about this and we talked a little bit about it before. I did want to let you know some things that you might, that might be coming before your board in the future during budget season. There may be a need to increase our staff in order to meet the CCMU requirements. We may need to look for contracted training staff and training resources. Not only for our own staff, but for community members. There may be a need for some field-based technology tools as we launch this later in the year.
What's a field-based technology?
Like an iPad to be able to do the telehealth out in the field.
Gotcha.
Translatable psychiatrist.
Yes, one of those also. It's also important to know that this is adding requirements on an already strained on-call system. So I want to, keep that in people's purview because that does have an impact on our ability to fill positions. And again, we're going to routinely ask your support and advocacy through your associations. Okay, Joyce. And then care report, I think, is the other big initiative that's coming up, and it's patterned a lot after drug court.
Yeah. This is a huge conversation. I think there's
People
so-
at home can't hear you unless you're talking on the. Sorry.
This is a big, I just didn't want to cut in front of
You go ahead.
This is a huge conversation and it is so controversial. And I think that there is an initial rollout, but for a rural county, particularly Inyo, this feels extremely unrealistic. It's like, what? You're going to say, okay, now you get to do this. And that's all well and good, but we need the infrastructure. If we're really going to provide a comprehensive system of care for people coming out of, or as an alternative to going to prison, there's a whole lot of very careful thought and planning that needs to go into that execution. And so it's such a controversial subject. But bottom line, it's a great idea in theory. However, the application has to be tailored to counties according to their, capacity to staff, a housing development of some sort or secured housing or whatever the need is, to have the physical care, psychiatric care, whatever we think we need based upon, what the feedback is from different areas of the county. So I think my opinion is that this is going to need a lot of input from the board and from people in your communities if we're going to, execute this in a way that's sustainable and that works. Because if it doesn't work, it would be disastrous. But we really do need a robust system for caring for people who are chronically ill and unable to take care of themselves. And there's so many people right now in jail who need to be in mental health care.
Yeah.
And the jail has been serving as sort of the de facto psych unit. And so I'm seeing, that we need something, but I don't think that, I think that if physically I feel myself wanting to slam on the brakes and say, wait a minute, so that's my 1 minute, 2 minute, 3 minute thing on care.
Yeah, so I'm an officer for CSAC, and so it's a huge topic that's come up. And the point I made and most rural counties make is there's no infrastructure now. Like, we can't recruit psychotherapists, therapists of income, substance use disorder people. But even if there's money, there aren't people to fill those positions, and then not even the residential treatment facilities.
Right.
So you can't get blood from the stone. And the other issue with that is that what happens when you have a judge or court that mandates services that you are physically unable to provide,
Yes.
or don't have funding to provide,
Yes.
or doesn't exist?
Yes.
That's not been clarified what that means. Fortunately, there's rural counties in cohort 1. They're going to have a little head start on us, and so hopefully some mistakes become apparent and get fixed. But you're right, it's a very heavy-handed aspirational approach that it's unclear how it will work out.
I think it's important to acknowledge that we hear you. It's well acknowledged. I think you're right on track. It's not a mistake to voice that.
Well, and I think and the intent around addressing issues like the number of persons who are homeless, who have chronic illness, is well intended.
Sure.
But I think Supervisor Griffiths was at a meeting with the governor a month or so ago,
Yeah.
and another county talked about in their experience, someone who's chronically mentally ill and homeless, that it can take on average 50 plus contacts before you make those inroads. We've experienced that here locally, where it took over a year to get someone to agree to, do X, Y, and Z, and another year to get that person actually housed. Putting a hammer and doesn't necessarily change the resources, and it doesn't change the time it takes for people to move from point A to point B.
Yeah.
Not alone, get to try and get to point Z, which isn't always very realistic. I think you've heard a lot of the challenges that we're experiencing around recruiting and retaining licensed staff, as well as SUD staff. When we have a vacancy, it's not easy to find someone to fill those vacancies. Right now, we have 3 vacant clinical positions in our core mental health program, and one that we established to meet the jail needs, and case managers, residential caregiver vacancies. On-call has consistently been cited as one of the contributing factors to our turnover. You've talked a little bit about it, whether it's SUD or mental health. Residential treatment facility access is challenging, especially in an acute phase where you're trying to 5150 someone, and then you are trying to, number one, find a place, and then find a way to get them there. Find a way to get them there. So facility to facility transports, especially when a person is aggressive or other safety factors are in place, is difficult. We have been very fortunate that our sheriff's department and our probation department have partnered with us around some critical access transports. And we have that benefit of having good working relationships, and so we appreciate that. And that is one of our strengths. We do have those partnerships, And then we have both clinical and non-clinical staff who are committed to the care of our clients. And some considerations that we may be asking and speaking with you about the future is allowing for, looking at what kind of flexibility do we have around what we offer in our workforce. I know our personnel has been working with the bargaining units around telework, remote work policies. Hopefully that might help provide some support. Consideration, in fact, of some of these more difficult to recruit positions of perhaps offsetting some of the costs might be an option that your board could consider as a policy issue in the future. And maybe, it's time to look at a work group. How do we do hiring and recruiting and retention differently in Inyo County? And I'm sorry if I sort of just took over here, but I know that my 30-minute estimate for a presentation didn't quite work out. But if there's questions on SUD, on our clinical services, our overall administering what we do from a behavioral health perspective, all five of us here are more than happy to spend your lunchtime answering.
Well, I guess, are there any comments or discussions from board members?
I'll make a comment that I feel really fortunate to have you guys heading up, this department, and I get it that there's a lot to tell us about, and so it's kind of hard to condense it down, but it's really good for me as a board member to see you guys here, and I don't have that much interaction with you, so
I would just say that being in a small rural county, that we do extraordinary things for our people who have these needs, and the credit goes to your team. So thank you.
Thank you so much for welcoming us. And all of us would love to answer any questions you have anytime. And thank you for letting us go.
Well, no, it's all good. I did want to ask if there was any public comment in the room, public comment or online, any questions.
Since we are horning in on his time.
I know.
I just have one quick comment, and that's, as my family has experienced a lot of mental health issues, including suicides and institutionalization over the years. And I know that this is a very challenging population to deal with, and I appreciate the difficult work that you do. It's such an important need for our community. For our families.
Thank you. Well, I think it's already been said, so I don't want to be repetitive, but I was just thinking the same. And I thought, counties are the last line of defense. I mean, we're the ones obligated, blessed and obligated to provide the services to people. And whether it's through things we read in the media or things we've experienced personally, constituents, I am grateful for what all of you are doing. And you've addressed some questions that have come, or how you're affecting change with some things that have come up just in my tenure here. So I appreciate it. And I think we're very fortunate to have people who dream to be here. So that's retention right there. So thank you. Thank you guys.
Thank you all. Love being here.
Thanks so much.